This is part two of cardiovascular and renal systems, and we start with nitrates. So nitrates were actually introduced for the treatment of angina as early as the 19th century. Their ability to affect both the oxygen supply and demand and their effectiveness in rapid relief of acute angina has made them actually one of the most important parts of treatment for angina. They provide more nitric oxide to the vascular endothelium, and that causes vasodilation. They can cause peripheral venous pooling because of the dilation of venous vessels, and that decreases preload. They can decrease afterload by causing arterial dilation, that is with higher doses, that decreases systemic arterial resistance. And together, these effects decrease myocardial oxygen demand, but they have little effect on atherosclerosis in the coronary arteries. So these are some of the side effects we see, headache being one of the most common, and that can persist in up to 50% of patients. Hypotension, because of all their effects, it leads to myocardial ischemia, arrhythmias, and then rebound hypertension. You can get a contact dermatitis from the patches. Concurrent use with vasodilators can be a real problem in terms of hypotension. Also with other antihypertensives, alcohol, beta blockers, calcium channel blockers. And they are excreted in the kidneys and the lungs. So these are the routes of administration, oral being most commonly used. We also have ointment and transdermal topical systems. These are the doses for acute anginal attack and also for stable angina where we're basically managing symptoms. So interestingly, to prevent or reduce the development of tolerance, you need a nitrate-free interval of about 10 to 12 hours a day. And that's why the nitro patches are applied and removed within a set period of time. So if around-the-clock coverage is necessary for anginal symptoms, using a beta blocker, calcium channel blocker during that nitrate-free interval might be needed. Next, I'm going to discuss peripheral vasodilators, hydralazine and minoxidil. They're not used as first line for hypertension. Really don't see them used very much, but they can be used in treatment-resistant hypertension and peripheral vascular disease. They act by direct relaxation and dilation of the smooth muscle in the arterioles, and thus they decrease peripheral vascular resistance. Peripheral vasodilators have limited indications. They can be used in heart failure when they're also used with isosorbide and dinitrate. They're not a primary drug of choice in recommendations and guidelines. So their adverse drug reactions can be related to the compensatory responses in the sympathetic nervous system and the RAS system, tachycardia, increased contractility and output, sodium and water retention, and headache. Lipid-lowering agents. Use those a lot. These are the classes of the various different drug therapies that can be used for dyslipidemia. So we'll start with those that we target lowering of LDL. Statins. Statins are the reductase inhibitors that are first line. This is the list in order of potency, Crestor and Lipitor being at the top in potency. Niacin can be considered, it has some benefit in lowering cholesterol LDL. It can also raise HDL, but that effect may not necessarily be true. We've often thought that we could start patients on niacin. I've done that in the past to raise HDL and to lower triglycerides, but that is no longer really considered to be a recommended treatment. The bile acid sequestrants may be used in low-risk cardiovascular patients along with diet, but we basically go right to statins. So lowering very low density lipoproteins and triglycerides, we can consider fibric acid derivatives. The fenofibrate and gemfibrocil are the most potent for triglycerides. The bile acid sequestrants and statins can also lower triglycerides, and omega-3 fatty acids, Levanza, and then there are some over-the-counter omega-3s that can help lower triglycerides. We do see increases in HDL of about 30%, but really we're not really sure what the benefit of that is. So that's why we really aren't using much of niacin. It has a lot of side effects. Patients really have difficulty tolerating it, but what effect that really has on outcomes has been really suspect, even if we can get that HDL increased. You can also use gemfibrocil and fenofibrate, as I mentioned, and next the statins. But they don't do as much in raising HDL as they do in lowering LDL. They may have a 15% increase in HDL. Statins are really where it's at. They block the synthesis of cholesterol by competitively inhibiting the HMG-CoA reductase activity. They can decrease LDL levels by 25 to 65%, depending on which you use and depending on the patient. There can be some decreases in triglycerides and some increases in HDL, which I mentioned. But they have been given the pregnancy category X, which of course I said is the old way to caution against pregnancy. Basically, you do not want to use them if a patient is at risk for becoming pregnant. You should even consider not using them at all in patients that are of childbearing ability. You could say that you could use good birth control methods. You could use 2 birth control methods. You can have patients sign their life away regarding risk of pregnancy if you really need to use them in these patients. But generally, most of the patients that, at least in the primary care setting, that are in need of statins truly are in the postmenopausal years. This shows the interactions because of the CYP3A, and I'll let you just look at that. Adverse drug reactions, commonly headache, myalgia being really number one. It's what we hear about all the time. Patients just don't feel good, their muscles ache, they feel like they can't move as well sometimes, and they're very much aware of these side effects and often will not take one because they've heard so much about them from friends and family. This side effect can be approached by being very judicious in your initiation of the statin, even if you have to go with underdosing them, going with every other day dosing, 3 times a week dosing. Sometimes patients will do better if you start slow and raise it gradually. It at least gives them confidence in what they're experiencing in terms of reactions. They also can get headache, fatigue, GI intolerance, and sometimes people just have flu-like symptoms, which most people aren't going to live with those on a daily basis. Rhabdomyolysis occurs in only 0.1 to 0.5% of patients. Some agents are more likely to cause that. Usually it can be according to potency and dosing. So, but you can have more of an effect if you combine them with fibrates. So drug interactions can be something to consider. Sometimes switching to another statin will help. Increase in liver enzymes is not usually enough to warrant frequent labs. So, we need to be aware of this. We need to be aware of rhabdomyolysis. We don't routinely check CKs to see if a patient should be, taken off them. And we don't routinely check liver enzymes maybe once after starting. And usually these patients are checked on a year-to-year basis anyway. Patients that have vitamin D deficiency, interestingly, seem to do worse in regards to the myalgia symptoms. So we just make sure that we want to have patients taking vitamin D and not developing a deficiency when they're taking statins. So we do like to start with a lower dose and increase as needed according to our response to LDL. And actually, that statement is somewhat old. We don't actually look at absolute levels of LDL. They're not as closely monitored. We now have categories of risks. People are put into these categories, and that determines whether they even need a statin. It's not just based on numbers. And those categories of risk also indicate whether they have very intense therapy, such as a highly potent high dose of, say, rosuvastatin, which is the most, or Crestor, versus lower risk category where they may be able to take a lower intensive therapy, one of the less potent ones, or at low doses. So that's pretty much how we dose statins these days. Monitoring of statins. Usually we check lipid levels around 3 months after starting them. I don't usually go with the 4 to 6 weeks, and I don't usually go with every 3 to 4 months until control is established, because the guidelines no longer recommend having those big, targets and dosing according to what the numbers are. We dose according to what the level of risk is. So we risk stratify patients. That's more for future courses to discuss. Liver function tests should be checked prior, and they should be checked. They could be checked when the lipids are checked at 3 months. And then usually it's on a yearly basis. The fibrates inhibit cholesterol synthesis. They can decrease triglyceride synthesis and inhibit lipolysis in the adipose tissue. So they have an effect on lowering total cholesterol, LDL, and triglycerides, and can also increase HDL. These are the fibrates that are available: nausea, diarrhea, gallstones, phototoxicity. These are some of the adverse reactions, and they have some interactions as well. And so this is a reason to, really reconsider whether we're going to add a fibrate. Again, you can monitor the lipid levels, looking at LDL. Check the LFTs before starting and as needed. Bile acid sequestrants. They can increase bile acid excretion, so they enhance the conversion of cholesterol to bile acids in liver, and thereby increase the uptake of LDL. Again, whether these should be added is questionable as to how much benefit is actually gained from adding this class of drugs. They do have a good safety and efficacy rating, and are most useful in patients with moderately elevated LDL levels and low coronary heart disease. I think the thing to consider is that while we love to use statins in everyone, some patients just aren't going to agree to that because they know that there's a reputation for side effects. So this could be the role for bile acid sequestrants and fibrates. These are some of the adverse reactions that we might need to consider, and there's also drug interactions. Monitoring again, pretty much the way we would normally do with anything else. Getting back to niacin, it does inhibit free fatty acid release from adipose tissue. It can lower total cholesterol, LDL, triglycerides, and it can elevate HDL, but its use is questionable. There does seem to be some lowering of ischemic heart disease related mortality, maybe in also decreasing the risk of recurrent MI. But other than that, it's gone out of favor in terms of its effect on overall morbidity and mortality. So we aren't using it like we were some years ago. So niacin can be obtained over the counter, but those doses are not sufficient to lower LDL levels. So patients may not have the flushing side effect, but they also don't really have much of a cardiovascular effect either. We can prescribe them as an adjunct to bile acid sequestrants or statin or whatever. And in patients that have really high triglycerides and very low HDL levels, we might add niacin. One thing to keep in mind is that aspirin given 30 minutes before a dose of niacin may prevent the flushing that people get from that. And you can see what usual dosing is here. Side effects, as I said, flushing is the major thing. You can also have some GI effects. And glucose control can be affected. There are some drug interactions, especially with alcohol. Again, checking levels of lipids. I don't think that's something that we would routinely do with starting niacin. Most often, as I said, it's used to try and elevate the HDL. Again, you can tell patients, as far as education, to take aspirin 30 minutes before the niacin dose. And that is a good recommendation anyway for people who might need niacin to be on an aspirin, and you can just have them take their daily aspirin 30 minutes before the dose. Zetia is something else that we can consider using in combination with a statin if we want more reduction in LDL and triglycerides, and it can also increase the HDL. Again, I have pregnancy category C here, but that just means use with caution in pregnancy. We also have the PCSK9 inhibitors, and pro-protein convertase is an enzyme encoded by the PCSK9 gene in humans on the first chromosome. So these drugs, Repatha and Praluent, inhibit pro-protein convertase binding to the LDL receptors. So they can dramatically lower LDL beyond what we see with statins. They can also act as a monoclonal antibody by decreasing LDL receptor degradation and increasing LDL clearance. These are not drugs that are used first line for primary hyperlipidemia. The annual cost is prohibitive, $14,000. Obviously, they're not going to be approved or covered by insurances for patients who just have primary hyperlipidemia. But people who have extremely high cardiovascular risk and very high lipid levels due to a genetic predisposition on this chromosome, are patients that are targeted for Repatha and Praluent. So this is actually an evolution in lipid care. And there's no increased risk for diabetics as may be seen with statins. Diuretics, our next group of drugs. So we have three classes: the thiazide diuretics, with hydrochlorothiazide being used most often, the loop diuretics, both of which can cause hypokalemia, and then the potassium-sparing diuretics, which can cause hyperkalemia. The adverse drug reactions, of of course, would be hypo or hyperkalemia, depending on which one we're using, hypotension, a decrease in GFR. That's something we have to monitor. We have patients that have other reasons to have a low GFR, so we want to be sure that it's not the diuretic adding insult to injury. Monitoring, of course, blood pressure, heart rate, edema, weight gain, etc. And checking levels of electrolytes and renal function before starting them is always wise. If we're using loop diuretics, we have particular concern about loss of potassium. And we do need to monitor those more frequently, especially in patients that have frequent dose adjustments because of their heart failure. Patients should be told to monitor weight, especially if they're taking the loop diuretics, because those are ones most often used in patients with heart failure.